So I would like to start with the first question. What are the most common short-term risks following bariatric surgery, and how often do we encounter them?
Of course. Well, I will answer the second question first. How often do we encounter them? Not commonly. Okay, complications can happen like in any surgery, of course, but with bariatric surgery, the way it is currently set up, particularly in centers like ours that are accredited centers of excellence, the quality and safety of bariatric surgery is extremely high. Nevertheless, it is surgery, and as surgeons, we know that in any type of surgery that we perform, the potential for complications is always there. The question is, what's the best way to deal with the complications, and how do you actually deal with them? And that's a very important topic for us as well. In terms of what are the most common early complications of bariatric surgery, it is probably useful to talk about the more serious types of complications. And those would be three. One would be infection caused by a portion of the stomach or intestine that fails to heal properly. It's something that we call leak. Another potentially serious complication is the formation of blood clots, either in the legs, the lungs, or even in the intestines. The third potentially serious complication that can occur early is bleeding. Now, these are potentially serious complications, and of course, they can be life-threatening as well. But the good news is, as I said earlier on, these are extremely rare. More importantly, we do have excellent methods for prevention, and so that's why we don't see much of these complications. But also we have excellent approaches of rescuing patients who do encounter these complications for us to be able to take care of them in a timely fashion so that patients can safely navigate out of the complications.
So most of the complication does happen in the short term anyway, right? So that we understand that.
Yes. So yes.
We know this right away.
Yes.
In many cases.
Yeah.
So, and then second kind of like a short term, the next level short term is within 30 days. And then after that, usually we don't see anything. At least I don't hear much from what we are doing.
Right.
And that's kind of true for probably other programs as well.
Yes, absolutely. So just looking at these three potential complications that can happen either with the gastric sleeve, the gastric bypass mainly, but they can obviously happen with the lap band and of course with revision surgery as well. So just to give you an idea of the time frame, right? So of the three potential complications, the infection due to leaks, the blood clots, and the bleeding, the one that can happen most at the earliest time would actually be bleeding. Bleeding can be seen, in fact, it is usually seen within hours of surgery. That's why, as you know, in our surgery center, the most intensive monitoring time is actually the early hours after surgery by having the patients being on a monitor where we're looking at their heart rate, we're looking at their blood pressure, we're looking at their oxygenation very, very frequently. Okay, like all the other complications, the best way to deal with this complication is to prevent it in the first place, right? And that's where we focus on prevention of all the factors that could increase the potential for bleeding, whether it is the timing and administration of blood thinning medication, for instance. All our patients get a blood thinning medication. Why do they get that? Because we want to prevent blood clots. But when you give somebody a blood thinning medication, you increase their risk of bleeding. So where we focus is the timing of the administration of that blood thinning medication is critical because there is going to be a time where the level of that medication is fairly high and the risk of bleeding is higher at that time. Right? So we focus on that timing importantly. Secondly, we try not to give additional medications that could increase the risk of blood thinning, or we time them in a way that there is no overlap between these two medications. And then finally, of course, as I said, because it can happen early after surgery, we are monitoring the patients very closely for any potential signs of bleeding. The other complication, for instance, blood clots, generally blood clots tend to occur if they do within 2 to 4 weeks after surgery. So there is a more extended period of time. There are the best.
Is that because of the patient compliance with the medication? Is that kind of the issue?
Well, it is a number of factors. So blood clots generally can occur after any type of surgery, which means that surgery by itself, the administration of anesthesia and performance of surgery, particularly certain types of surgery, puts the patient at a higher risk for blood clots. But there are other factors that can increase this risk. For instance, patients who have a very high body mass index would have a higher risk. Patients who've had a history of previous blood clots would have a higher risk. Patients who are above the age of 40 will have a higher risk than younger patients. And patients who are not as mobile, for instance, if they are on a wheelchair, they cannot walk too much after surgery, they will be at higher risk. Patients who have had a history of some types of cancers would have higher risks. All these are important factors that we put into consideration when we apply preventative measures, right? And as you know, the preventative measures, the most important for us is to get the patient up and walking early after surgery and for them to continue to do so during their recovery. And we do this very, very well, and it's based on education. But the other thing we do, Kemal, is we provide compression stockings around the legs of the patients that are actually dynamic. They compress the calves of the patient so that blood circulation from the legs is increased. And it happens despite the fact that the patient is immobile because of the anesthesia. So those help us greatly. And then the other thing we do additionally is, as I said, we administer a blood thinning medication, which surgeons in the past, when we were doing these open surgeries, we dreaded the idea of giving a patient a blood thinning medication before surgery. But now we can do it comfortably because of the advancement in technology that allowed us to do surgery through very small incisions and with a lot of precision. And how about leakage infection? Well, that can actually occur usually after between the 2nd and the 6th week after surgery. That's the time frame that it can occur. And so, again, we pay a lot of attention to factors that could increase this. For instance, gastric sleeve is the one where leaks can happen a little bit more commonly than gastric bypass, for instance. And why is that? Well, because the stomach is so small and narrow that the pressure inside the stomach rises considerably, putting a strain on the suture line of the stomach. So reinforcing the suture line with additional material, as you know, the Surgery Center provides this for us, is very important. But more importantly, also understanding the geometry of the sleeve so that there is no increased points of pressure on the stomach is very important. All those are very critical factors to minimize the risk, but it can still happen for a number of other reasons, right? So what do? We educate our patients for them to come back and tell us if there are any potential signs of an infection. In fact, the standard education we give our patients is that after they leave our center, they should continue to progress in their recovery. If they feel they are going backwards, having pain more than they've had the day before, having nausea, vomiting, or fever, all these are signs that should alert them to call us so that we can look into it in a timely fashion and so we can address this issue. So to summarize, bleeding can happen within hours. Blood clots can happen between the 2nd and 4th week, most commonly. And infection is caused by leak usually will happen between the 2nd and 6th week after.
So our percentages for these are in like 1 in thousands, 1 in 1,500.
Very low, so very low, very low.
We don't see them very often. So it's one of the reasons when we talk about these risks and complications, if there was an ongoing issue, but we don't. So now, one of the reasons it doesn't happen also, as you were explaining from the patient education process, but also our patient screening process is probably one of the best in the country in terms of the bariatric. And it's kind of interesting. I don't know if you felt the same way when we were going through some interviews with some new surgeons. I can see how they were kind of shocked. And these guys are coming from good programs. And what we do on a day-to-day basis with the case conferences and just taking the patient from the consult to the surgery, then having their follow-up appointments in the same program. So it just doesn't happen in every other program. And then that's probably why we're also having a better outcome with these. And it, just like anything, it just comes down to the prevention.
Yes.
And then that prevention is, in this case, either the clinical team needs to do certain things. Our database helps us to flag any and every other issue that we may
Yes.
see. And sometimes like you can probably attest to this. So I ask the same question, even though I know the answer, just to make sure that I get the same answer, so that because in one thing that we don't want to make any assumptions. As
Absolutely.
you always say, in the clinical setting, the duplicate.
Additional levels of redundancy.
Duplicate
right?
redundancy is one of the good things in clinical settings.
Absolutely.
So it may not be so efficient in other settings, but
Yes.
this is where we need that. And therefore, that also helps our patients' outcome as well.
Absolutely.
Now, I want to talk about the nutritional deficiencies and kind of like overall explaining to those who are going through the process, what are the nutritional deficiency, and is it like long-term, and what can they do to address those concerns ahead of time?
Absolutely. So essentially, one of the ways in which bariatric surgery works is by decreasing the amount of food the patient consumes, right? Because that will lead to a direct decrease in the caloric intake as well, right? But when we are interfering with the patient's ability not only to eat food, but also to process that food by making changes in the digestive tract, yes, we are succeeding in decreasing their caloric intake, but we may be interfering with the patient's ability to take in absolutely necessary nutrients, the so-called micronutrients. And these are clearly vitamins and minerals. Now, this is much more pronounced with procedures where there is intestinal diversion or intestinal bypass, like the gastric bypass or the duodenal switch. It is less significant, less impactful rather, with a procedure like the sleeve gastrectomy, where there is only interference with the stomach and not with the intestine, and of course, even less so with the lap band. So what we have to do is we have to educate our patients about this fact that will become a reality in their post-surgical life, right? And we also educate them of ways to minimize its occurrence or avoidance of this problem totally, right? And this is based on getting them to do two things. One is to make sure that they have multivitamins and minerals appropriately on top of what they're eating. So all our patients will have multivitamins, but some patients may even need additional specific vitamins, like for instance, vitamin B12 or folate or vitamin D, particularly patients who've had intestinal bypass surgery. The second thing we want them to understand is that they need to follow up with us or their primary care with respect to checking for these deficiencies, which means they have to have blood tests done periodically. It doesn't have to be every month, but in the long term, they should have blood tests done at least once a year, if not twice a year, and then address deficiencies that are reported on that blood work. And this commonly will show, for instance, vitamin D deficiency. Sometimes we will see B12 deficiency. Sometimes we will see B1 deficiency. I saw a patient today who had a vitamin A deficiency. So all these need to be recognized and addressed, and they can be prevented as well by having the patients become compliant with the intake of vitamins and micronutrients as they have been taught by our nutritionists, right? Another important factor, of course, is to understand also that if they focus on foods that are rich on these micronutrients, then there is going to be less likelihood of deficiency. Right. If they're going to focus, for instance, on processed food, on so-called junk food, or food that has a long shelf life, for instance, as opposed to freshly gathered food, then they are going to be at risk of deficiency. So these are the things we do. But also the other important thing to understand is we're not just worried about seeing the deficiency in the blood work, right? The deficiency in the blood work is obviously information, but what is the consequence of that deficiency? Well, if that deficiency is not addressed, the consequences could be even severe. They could lead to hair loss. They could lead to poor healing if there is a wound. They could lead to weakening of bones or even to permanent nerve damage with certain vitamins. So it is very important that patients understand that, are well educated and versed on this, and then follow our recommendations to really avoid and prevent these deficiencies.
So today we are going to discuss the bariatric surgery time. Yeah. So this is usually how we set the tone with our patients in the beginning. So what we are going to do and what needs to happen with them and how they're going to actually take charge of their future. So this is one of the important topics that we discuss at the time of the first consult. It doesn't mean that we don't discuss this later on, but this is the foundation of that decision. Okay, you are here, and now we kind of need to decide what type of surgery is the best one for you. So that's why we have the expert here. And Dr. Irgau, what would you like to tell us about the different surgery types? And then I'll have some questions as we go through.
Absolutely. No, sure. Thank you. Thank you. It's always great to be here. And then, although, as you said, the topics are very similar in many ways, we really present them in a conversational manner, emphasizing one aspect of the topic specifically in one session. So watching them is not necessarily watching a rerun of the same topic. Essentially, there are different ideas that may be highlighted on different sessions. As you say, today we're going to talk about types of bariatric surgery. And clearly, it's probably better to first talk about what bariatric surgery is, right? Bariatric surgery really is a surgical intervention which is aimed at making some change in the digestive tract so that we are able to influence hunger level, fullness level, and to some extent, the metabolism that is involved in energy processing in our body. And it's important to emphasize this because people have different ideas about bariatric surgery. Very often, it's not uncommon for me, for instance, to tell people I do bariatric surgery, and the first thing that comes to their mind is I take patients to the operating room and I remove all the fat that is visible in them, right? And or they think about something like liposuction. It's not uncommon for me to ask patients whether they've had any type of weight loss procedure, and they say, yes, I've had liposuction. Well, liposuction is a procedure where fat is essentially removed by the body, but it's not a bariatric procedure. It's more of a cosmetic procedure because really it has very little impact on the metabolism of the person. On the other hand, bariatric surgery is way more impactful in terms of what it does to our physiology. And it's useful to look at the bariatric procedures in terms of the ones where there is a change in the size of the stomach only, or procedures where there is also rerouting of the intestine. And that's a critical difference. Really, there are two main types of bariatric surgeries that are commonly undertaken in the United States or even in the world right now, right? And that is the gastric sleeve or the gastric bypass. Also, there is another version of the gastric bypass known as the duodenal switch as well, which is done less commonly. Other procedures that people may have heard of, the gastric band, the gastric balloon, are also undertaken, but to much lesser extent. Mm-hmm. So let's talk about the most commonly undertaken procedure, which is the gastric sleeve or sleeve gastrectomy or vertical gastric sleeve, as many people know it. Well, with this procedure, what we do essentially is we focus on the stomach itself. And the normal stomach has the shape of a watermelon. Not only it has the shape of watermelon, but it acts like a balloon, which means that when we eat, if there is more food coming, the balloon actually stretches and distends. So we are able actually to out-eat, to overeat whatever plate is presented to us because our stomach is such such a shape that it can really accommodate a lot of food. Well, when we do the gastric sleeve, we really attack that ability of the stomach by making the stomach a lot smaller, not only just smaller, but by removing the portion of the stomach that stretches the most. So when we're done with the procedure, a stomach that started like a watermelon shape now will look more like a banana. That is the essence of the gastric sleeve.
Now, at the time of the consult, in order to decide which one is the most suitable procedure, how do we actually make that decision? Patient may come to us with some made up decisions, but that may not be the best for them. But what's that process? How do you decide which surgery is the right one? And then I have some follow-up.
Of course, that's a very important question, obviously, because that decision, although it is a shared decision between the surgeon and also the patient, the surgeon will play a very important role, obviously, in guiding the patient because the surgeon has the experience, the knowledge, and the know-how as well. I can tell you that for the vast majority of patients, any of those procedures will be fine in principle. In fact, when patients tell me what is the worst procedure I can have, I tell them the worst option would be to do nothing. And let obesity run wild, obviously. So any of those interventions are fine. But clearly, some interventions are much better applicable to an individual than others. In general, it is no surprise that the vast majority of patients nowadays in the United States or even in the world choose to have the gastric sleeve or the sleeve gastrectomy. And the sleeve gastrectomy is appealing and applicable to the vast majority of patients because of its intuitive simplicity, right? The stomach is big, the stomach is distensible. Let's make it smaller so we can eat less food. We have less hunger, but also there are other metabolic benefits of the procedure. And it is a procedure that has a proven track record, not only in its results, but also in its safety. We talk about how the gastric sleeve, Kemal, now is as safe as very commonly undertaken surgical procedures like the gallbladder surgery or hysterectomy or even appendectomy to some extent. So the vast majority of patients who are looking for a robust weight loss, we're talking about patients wanting to lose 60 pounds, 80 pounds, 100 pounds, 150 pounds, the gastric sleeve will do with that safety track, but also with the fact that the gastric sleeve does not require rerouting of the intestine. Rerouting of the intestine, which is a process that is done when we do the gastric bypass, introduces issues and problems for the future that the gastric sleeve doesn't have. Having said that, there are some patients on whom the gastric sleeve may not be appropriate, right? For instance, patients who have had a very long history of acid reflux to the extent that that has caused damage to their food pipe, something that we call Barrett's esophagus, for instance. In that case, we say maybe a procedure that removes acid exposure from the food pipe, like the gastric bypass, is better applicable for the patient. So we discuss about the advantages and disadvantages of a procedure like gastric bypass as well. Both procedures, as we have said in the past, are procedures that we perform in our practice and we offer, and they are very often done in our bariatric center, which is the American Surgery Center, where the vast majority of the procedures are undertaken laparoscopically in an outpatient setting.
Now, the most common procedure that we do is gastric sleeve. In almost, I would say, 75 to 78% of cases.
Yes.
And another 22% is bypass. So gastric bypass is more, I guess, invasive in a way. But in some cases, it's the only choice that patient really should go. And in the case of managing diabetes, as you mentioned, the reflux, other than just the structural changes, there's an important part that patient needs to understand what both can do. So in one of them, literally, we don't actually have any stomach functions, so that there will be a very little space there. But at that point, that's what they need. But if it's a 25-year-old patient or 27-year-old patient comes to you with no diabetes or reflux, that wouldn't be the go-to procedure. Is that correct?
Absolutely, absolutely. There is a misconception sometimes come out thinking that there is a difference in weight loss between the gastric sleeve and the gastric bypass.
Mm-hmm.
By and large, those differences are not major. They're not very, very significant, right? So I think it is important for patients to understand that. Another misconception that I come across very often is patients saying, well, if I have the bypass, I will never regain weight. If I have the sleeve, I could regain weight. Well, that is actually not necessarily correct. In fact, patients can regain weight with any bariatric procedure. There was a bariatric surgeon that was teaching us when we first started over 20 years ago, who used to say, you can out-eat any bariatric procedure, which means that if you don't change your behavior, it doesn't necessarily mean that these procedures will do a magic thing for you, right? All patients have to understand that the biology that drives obesity is just around the corner, even when the surgery is performed. So they have to be careful. They have to be mindful. So we're not saying diet and exercise have failed. Let's replace them with surgery. We're saying diet and exercise are not powerful enough by themselves. We're going to add a powerful tool to them, which is surgery. So we want you to exercise. We want you to focus on your diet still. And the surgery will be an extremely powerful tool that will allow you to lose the weight.
Well, obviously, the other important thing is if someone is able to make the necessary changes, necessary adjustments, so then they have the surgery, then that's it. So then they don't have to be on, not only they don't have to be on any medication, but if they're on medication for hypertension, diabetes, and other comorbidity-related, obesity comorbidity-related diseases, then they can be actually off medication, including sleep apnea and other conditions.
Absolutely. On that point, actually, I would like to emphasize one fact. Yes, there are, in terms of weight loss, there may not be major differences, but there are other important differences between the gastric sleeve and the gastric bypass, right? For instance, it's, as you mentioned yourself, the gastric bypass is much more powerful in really taking care of heartburn or acid reflux when it's compared with the sleeve. And also the gastric bypass has much more impact earlier on after the surgery on the resolution or improvement of type 2 diabetes. There is no question about that.
Can you elaborate the reflux a little bit? So like when you say reflux, first thing that, like, I'm not speaking from my position standpoint, but if I was the average Joe, the reflux is like if I'm burping. Is that what it is? Or
it's
like,
not. It's not. It's not just burping. Reflux essentially
these questions do come to me. That's why I'm asking.
That's right. Reflux essentially is the result of acid refluxing back into the food pipe. So if we look at the actual inside of our digestive tract, we look at the food pipe first, which is a tube that connects our mouth to the stomach. And then there is the stomach. Now, if you look at the contents of these two structures, you will see that the stomach can withstand very, very high levels of acidity. In fact, acid is produced by our stomach to help in digestion, whereas the food pipe does not have any acid, and its lining is not made to really withstand acid. So if acid comes back from the stomach into the food pipe, it actually damages the food pipe. And we feel that. We feel that acid coming back in our food pipe because we don't have a food pipe that is really made up to withstand acid. There are mechanisms that protect the food pipe from the acid coming from the stomach, but those mechanisms, sometimes they can fail, and that's what we have acid reflux, essentially.
So, but what's the cause of that, though? Like, why is the acid coming out and it's not staying in the stomach?
So, essentially, there is a valve-type mechanism that protects the contents of the stomach from coming back up into the food pipe, right? Those mechanisms are not just like a single valve, but there are the anatomic position of the stomach itself, the opening within the diaphragm, the muscle that divides our chest from the abdomen, has a very important sling-like structure that really constricts the food pipe and prevents things from going back up. But those things can fail for a number of reasons. Interestingly, one of those reasons is actually gaining weight and having increased the intra-abdominal pressure, gaining weight and leading to laxity of those valve type of mechanism. Pregnancy in women can do that. In fact, many women who don't have any reflux normally will experience reflux during pregnancy. So that can happen as well. But that can also be exacerbated by diet. It can be exacerbated by excessive alcohol intake and also smoking. All things that should also be addressed when somebody is having reflux problems. Now, it is important to understand that there are different degrees of reflux symptoms. There are some people, for instance, who will tell you, I have reflux if I eat something, acid type of stuff. Yeah, absolutely. That picture is actually very, very good in showing what we're talking about.
Right.
So there are some people who say, for instance, they have reflux every night and they have to take medication. So we have to really understand these degrees before saying, yes, surgery should be undertaken that will address the reflux issue as well. One thing that is also important for people to understand is that if they have mild or reflux that has not been there for a long period of time, having the sleeve gastrectomy and losing weight may by itself address the reflux issue. So just having some symptoms of reflux doesn't necessarily equate from, to going to gastric bypass.